The tendinous cords are not formed, so we just have an aneurysmal shape to the septal leaflet. And following further up towards here, the anterior superior leaflet, the commissure again is not that well formed. The medial pepillary muscle is not clearly seen at all. And following up here, the anterior superior leaflet. You can see this is again grossly malformed. We have a huge sail-like appearance of the anterior superior leaflet. And I can show you further examples which show variations in its distal attachment, which gives you the various, the huge variation in morphology of Epstein's malformation.
Was there any VSD under the tricuspid aneurysm that you showed?
No, there was not a VS. There was an intact septum. Yeah. Here we see, if we can get a little bit closer. Stop. Right. We are looking down the junction, the right atrioventricular junction here. Here's the level of the valve orifice. Again, we pick up the coronary sinus for location, for orientation. And we're trying to look down into the right ventricle, but the light is giving us problems today. We can see the anterior superior leaflet is malformed again here. The commissure between anterior superior leaflet and septal leaflet. The septal leaflet again completely plastered down, and then the inferior or mural leaflet not showing anything at all. The way that the leaflet or its remnant has terminated in this heart is that it's way down at the junction between the inlet portion of the heart and the apical trabecular portion of the heart, so that there is like a shelf across in this part that prevents flow from entering behind to try and get into the apical portion, except through this rather keyhole-like orifice between the septal leaflet and a very malformed anterior superior leaflet. So again, the junction or the valve is described as being apically displaced. If we look at the orifice from the outlet side, I think this is rather more dramatic. Here we see the muscle bundle or the muscle band or shelf, whatever you like to call it, that crosses the cavity of the ventricle, and to this band is attached the distal portion of the anterior superior leaflet. So this arrangement is described as the linear form of attachment, and without any intercaudal spaces or any holes left in this place, in this part, for blood to enter the apical trabecular portion. Flow is restricted to this little opening up here where I have the probe. So a keyhole opening for the outlet.
What course does the protection tissue take in the setting of the Epstein's nodal tricuspid?
I think the atrioventricular conduction system is normal in disposition. But what happens is that there are more occasional cases of Epstein's malformation associated with atrioventricular pre-excite with accessory atrioventricular connections. And this has been described as being due to a faulty atrioventricular junction.
Would this accessory pathways be in the right side? The right
Usually on the
ventricle?
right side,
Yeah, on the right
and
side.
also on the septal side.
Okay.
Now we have a further malformed tricuspid valve showing Epstein's malformation, and this time we have no distinction of the leaflets. All we see is this sort of thickening of the endocardium where the leaflet has failed to delaminate completely. We have a little bit of leaflet tissue left here, a little bit of the remnant attached there. That is part of the anterior superior leaflet. And otherwise, I'm trying very hard to get my probe through, but there's just a very tiny, tiny little orifice left between the septal and the anterior superior leaflet. So this is nearly the setting of an imperforate Epstein's malformation. Very severe stenosis indeed. Coming round to the outlet portion, we can see just a little bit of the leaflet tissue has formed, as we have seen on the other side. A lot of musculature across there, and the tiny little keyhole left for right ventricular outflow. So Epstein's malformation has lots of variations. This is probably one of the more severe malformations. Severest extremes example. It's usually associated with an atrial septal defect, and we can see this is where the repair has been across the atrial septum. We have another heart here showing perhaps in a view more familiar to the echocardiographers, showing a right atrium displaced attachment of the valve, a sort of shelf of valvular tissue across at the junction between inlet and trabecular components, and this sort of keyhole, sorry, not a keyhole, but this, in this case, associated with a ventricular septal defect communicating with the left ventricle on the other side through here. The probe into the left ventricle. So Epstein's malformation can be regurgitant and can be stenotic as well.
The previous case that we saw was same signs with ASD that was close escalating.
Yes.
Oh, that's why the patient died.
I think I'm not sure about the history of the patient at all. It's a very, very old specimen in the collection, yes. You can see the sutures are so enormous. No. Now they are moving on from Epstein's malformation. There are other malformations which affect not the annulus, but affects the valvular leaflet, and it can occur both in the mitral as well as in the tricuspid valve. In this case, a sort of thickening of the leaflet tissue, giving you valvular leaflet dysplasia, and in this case, giving a rather stenotic tricuspid valvular orifice as well. The cords in the chordae attaching the leaflets are somewhat thickened. There is a reduction in interchordal spaces, especially along here. What should be the area of the anterior septal commissure has become obliterated, like a continuation of the one leaflet running onto another. There are other malformations affecting the leaflet tissue, showing again in this heart the tricuspid valve that is affected. I'm trying to get into the outflow tract of the right ventricle with the orifice tricuspid valve being probed. This is the anterior superior leaflet. As you can see, there are extra strands attached to it. And down here we have an accessory leaflet which is attached to some papillary muscles towards the apex down there. And this accessory leaflet tissue has been pushing in and out of the right ventricular outflow tract as demonstrated here. So here's the outflow to the pulmonary valve, and in life it was actually moving up and down in this direction and blocking off the right ventricular outflow tract. And this is an example of a windsock malformation of the tricuspid valve. Can we see the hole in the windsock is just there, right at the end. So quite an exquisite example, but not all that common. Another malformation of the valvar leaflet is shown here. In this case, let's look at the mitral valve. We have spread open the mural or the parietal leaflet. We have cut through it and spread open the papillary muscles, giving an impression that the papillary muscles are situated miles apart. Well, of course, this is not true in real life. But it does show you quite nicely along the aortic leaflet is a very nice cleft of the mitral valve. Now the cleft of the mitral valve in this case is not to be equated to the so-called cleft of the atrioventricular, to the valve guarding the atrioventricular septal defect, as you have seen in the last presentation. This cleft of the mitral valve points up towards the aortic outflow tract. As you can see, if I reflect away this piece of myocardium here, this is the cleft pointing towards the aortic valve, the ventricular septal defect here. The cleft of the mitral valve is quite frequently seen, perhaps not all that frequently, but there is an association between the cleft of the mitral valve and complete transposition of the great artery. And this cleft would give mitral incompetence rather than restricting flow into the left ventricle. There are also other malformations of the valve leaflets which I am not showing you this afternoon. For instance, there is prolapse of the valvar leaflet, seen especially in the mitral valve, associated with rupture of the cords supporting the leaflet. Now there are other lesions which give problems for the valve, and in this case it is affecting the mitral valve again, left side of the heart. And this is an example of a parachute malformation of the mitral valve. Now the parachute malformation occurs most commonly in the mitral valve and very, very rarely in the tricuspid valve, although the first description of a parachute valve is that of a tricuspid valve. The definition also of a parachute valve differs from different sources. Some describe a parachute mitral valve or parachute valve only in the setting of a solitary papillary muscle supporting the valve. Some other people would describe a parachute valve also when there is fusion, for instance, between the two groups of papillary muscles supporting the mitral valve. And yet other people would describe a parachute valve where, for instance, in this heart there is one distinct group of papillary muscle here, the posterior medial. The anterior medial papillary muscle is extremely hypoplastic, so that if you're examining the heart grossly, there would appear to be only one group of papillary muscles. So some people even describe this situation as a parachute mitral valve, but I think it is more accurately described as hypoplasia of one of the papillary muscles. Other forms are the malformations that restrict flow to the valvular orifice, as in this case, involving the entirety of the mitral valve. As you can see, the orifice itself is very small. If I turn the heart around to the atrial aspect, the leaflets are very thick and non-pliable, leaving a small orifice there. Looking at the valve from beneath, the valve orifice again, the two groups of papillary muscles are visible or discernible, but there is a gross lack of intercordal spaces. In fact, the tendinous cords are very, very short, and the edges of the leaflets are very thick. So a very stenotic mitral valve, although all its component parts are present. Yet another type of malformation affecting the mitral valve is shown here. And here you notice an enlargement or dilatation of the left atrium, the valve orifice across there, or the annulus across there, the leaflet of the mitral valve, and down here we have, trying to spread this ventricle out there, we have the two groups of papillary muscles, anterolateral and posterior medial, and if we trace them up towards the apex, we find that they fuse across in a muscular bar right on the underneath the leading edge of the valve leaflet. And this situation, or this malformation, is described as an arcade lesion. So the papillary muscles are fused together across the tops, together with the valve leaflets. The name is an arcade lesion. There is lack of development of the tendinous cords across here. I'm not too sure.
Well, the left ventricle is extremely small.
Well, it's not terribly small, because it's on the small side, but it's not, I wouldn't call it as hypoplastic.
So it's not mitral atresia.
It is not mitral atresia. There is a patent pathway through. There is an orifice through. It's just that the leaflets are malformed, the cords have failed to form, and the papillary muscles have fused across at the tips. Well, there's no adequate opening exactly. Now I'm going to finish this seminar with other obstructions of flow, but this time to the ventricle, so it is not strictly speaking a malformation of the atrioventricular valve, but I think it belongs to the whole group of lesions that cause restriction of flow, or from atrial outlet flow restriction. If we look at this rather large specimen, first of all, a bicuspid arterial valve here. I'm not quite sure whether it's common arterial trunk or a solitary arterial trunk, because we don't have the superior portion of this great artery. But we look down the atrial chambers, I think you can quite readily see that we have quite a normal tricuspid valve on this side, but on the left side we try and get into the mitral valve. You see the mitral valve opening, Well, we have a membrane that is sitting right above the orifice of the mitral valve, a supravalvar membrane affecting the left atrial outlet. Now, turning to a smaller heart this time, but showing you something that's happening on the right side of the heart. And this is a rather interesting heart. I picked it up yesterday when I was looking for hearts with Epstein's malformation. And you can indeed see that, well, I pick up the coronary sinus again for orientation for this purpose. The atrioventricular junction across there, a displaced attachment of the atrioventricular junction or valve. Across here, there's no delamination of the septal leaflet. And I tried very hard to get to the apical portion, but I couldn't, so we have a situation again of an imperforate Epstein's malformation. But then I got more interested in the right atrial chamber because I find here the superior cable vein. I'm pointing up into the superior cable vein. And I put the heart back together, superior cable vein, opening it across the junction with the right atrium, and I come across this membrane. You see that? Picking up there. And I'm just passing my probe down into the inferior cable vein, and I'm going to try and lift up this membrane to show you that it is very large eustachian valve. A huge continuation of the eustachian valve that is crossed over to the atrial septum on this side and blocking the atrial flow to the right ventricle. Although in this case, of course, we have, as we determined just now, a situation of imperforate Epstein. But that is the only little hole that's passing through from the right atrium to the right ventricle. And this situation can be described as a subdivided right atrium, or partitioned right atrium, perhaps the equivalent of a partitioned left atrium. And continuing on this heart, I'm probing down there into the oval fossa and turning into the left side, we see a gross herniation of an aneurysm of the oval fossa into the left atrium. And that is really not surprising because right atrial flow really has nowhere to go but through the oval fossa. So what I've attempted to show you this afternoon are malformations of the various types of malformations of the atrioventricular valve, some variations of Epstein's malformations, and also attempted to show you in the last two hearts atrial outlet obstruction. Okay?
Well, good afternoon, ladies and gentlemen. The topic for this afternoon's talk is pulmonary atresia. And you're looking at one heart with pulmonary atresia. You can see that it has pulmonary atresia because here is the pulmonary trunk. The great arterial trunks are relatively normally related one to the other. You can immediately see that the pulmonary trunk is much smaller than the aorta. And if we turn this so that we can open the pulmonary trunk, you see that within the pulmonary trunk, the base is completely blind ending. There is no valvar tissue in the base of the pulmonary trunk. So there is no way for the blood to get from the right ventricle out and up into that pulmonary trunk. Now this is a particular type of pulmonary atresia, And I'm only showing you this heart with pulmonary atresia to make the contrast between the major topic of this afternoon's discussion. Because in fact, this is not a typical example of the heart with which I'm going to be spending most of the time. What is that? What have I just pushed the probe through? Yes, so which ventricle are you looking at here? Right ventricle. And you said I've just pushed the probe into which vessel? The aorta. So what have I just pushed the probe through? A VSD. So what would you call this heart? Pulmonary atresia with VSD. Absolutely right. There is the ventricular septal defect. You can see the valve, the aortic valve, in the roof of the ventricular septal defect. Here is the blind ending pulmonary trunk. Now, this is one variant of pulmonary atresia. Pulmonary atresia with intact ventricular septum. With pulmonary atresia with ventricular septal defect. Now, what strikes you about that right ventricle? Is it hypertrophic? Yes. The cavity? Very small? No. In fact, the cavity of this right ventricle is not bad at all. As you say, the wall is a little bit hypertrophic, but the tricuspid valve here is well formed. There is a ventricular septal defect that lets the blood get out into the aorta. And if we back off a little bit now, the main problem in this type of heart, which is pulmonary atresia with ventricular septal defect, is seen here on the back of the heart. And what are you looking at here coming from the descending aorta? Collateral arteries. Very good. These are collateral arteries which run from the aorta and run across to supply the hilum of the lungs. And look at this back of the aorta here. There are a leash of collateral arteries. There is one. There is another one that has been cut short. Here is one going over to the right lung. Here is another one that is coming over to the left lung. And if we trace these collaterals, what is interesting is that if we follow this collateral artery, which you see there running from the descending aorta, is running over here, and what is it anastomosing with at this position? What vessel is this? Pulmonary. That is the pulmonary artery. Absolutely right. And so you see there are pulmonary arteries within the pericardial cavity. There is the right pulmonary artery that I'm passing the tip of my probe into. There is the left pulmonary artery. You see the left pulmonary artery continues to supply the back up a bit, Lucian. You see it supplies the upper lobe of the left lung. And so this systemic to pulmonary collateral artery that has come from the descending aorta, now note that that is not an arterial duct. If it had been an arterial duct, it would come from the arch of the aorta here, opposite the subclavian artery. See, it's much lower down. It's not an arterial duct. It is a systemic pulmonary collateral artery that supplies the main pulmonary arteries, and therefore, through that systemic pulmonary collateral artery, the blood will reach all that part of the lungs supplied through these intrapericardial pulmonary arteries. But that is not the entire pulmonary circulation, because in addition to that, we've already seen that here is a part of the right lower lobe supplied by this collateral artery. There are these other very large collateral arteries that we haven't been able to trace. So the major problem in hearts that have pulmonary atresia with a ventricular septal defect is where? in the pulmonary arterial supply. The clinical problem in these hearts is working out what is going on in the pulmonary arterial supply. How much of the pulmonary arterial supply comes from central pulmonary arteries? How much of the pulmonary arterial supply comes from systemic to pulmonary collateral arteries? And the job that the surgeon has to do is to make sure that enough of the lungs are supplied through these central pulmonary arteries, that if a conduit is placed to those central pulmonary arteries, that will supply enough of the pulmonary parenchyma to ensure that the heart can beat properly when you separate the two ventricles and you close the ventricular septal defect. Because the surgical treatment of this heart would be to place a patch across that ventricular septal defect and then put a conduit from the right ventricle to the pulmonary arteries, providing we had ensured that those pulmonary arteries were supplying sufficient of the pulmonary parenchyma for the two sides of the heart to beat independently. Does that make sense? So the problem with pulmonary atresia with ventricular septal defect is in the pulmonary arterial supply. Now the heart that I'm going to spend the rest of today's talk discussing is quite different, because the problem in this heart is not in the pulmonary arterial supply. So what can anybody tell me about the heart that you're looking at in the screen at the moment? What are you going to call this heart? No? In fact, it has a minor degree of Ebstein's anomaly, but that is not what you would call it primarily, so that's not such a strange answer as at first it might seem. Let's come up the table a bit, Lucian. Thank you. What is the major problem what is the topic of today's talk? What have I just introduced you to? Pulmonary atresia. So this is pulmonary atresia with intact ventricular septum. Absolutely. And what am I showing you here? What chambers are we looking at? Right ventricle and right. In fact, someone is eagle-eyed. Someone did very well, because you can see that indeed there is minimal downward displacement of this tricuspid valve. So very good. There is Ebstein's malformation. But that is not the major topic of today's talk. We will get on to Ebstein's malformation. We are looking here at the right atrium. You can see in the back of the right atrium there is a hole there. What am I passing my probe through? ASD, what sort of ASD? Ostium secundum fossa ovalis ASD, which is better. There is the coronary sinus. In fact, you can barely see the coronary sinus. It's that little hole down there. So there is a coronary sinus, but that is an oval fossa atrial septal defect. Here is the right ventricle. Now what strikes you about this right ventricle? Which part of the cavity is obliterated? Now why is the outflet obliterated? What do you think that is? Do you think that is completely obliterated? Partially obliterated. What am I showing you there? What's this? And what is this? And the infundibulum is running all the way up to the undersurface of what? Pulmonary valve. Very good. That is the pulmonary valve. Now, in fact, that pulmonary valve, as you see it, looks dysplastic. We can't get any closer than that because these are relatively small hearts, but there is a division between there. That division was made after death. Before death, this valve was imperfect. Now this is crucially important, because what you are looking at here is the right atrium connected to the right ventricle. The tricuspid valve shows the minimal degree of Ebstein's malformation. We're going to talk about that shortly. But the important point is that the right atrium connects to the right ventricle. The right ventricle has an inlet. It has evidence here of its apical trabecular component. But Dr. Al-Marsafawi was correct when she said that this apical component is overgrown. And you see that there is huge muscular hypertrophy here. But the inlet, the outlet component rather, is still present. And the outlet component is perforate all the way to the undersurface of this pulmonary valve. So the pulmonary valve is separating the outlet component from the wall of the pulmonary trunk. If I can turn the heart over and show you the other side. Now, what are you looking at there? This is the left atrium, and what is coming into the left atrium? Pulmonary veins, that's very good. What is that? No. What's that the opening of? What is narrow and tubular and comes out of the left atrium? Left atrial appendage. That is the opening of the left atrial appendage. If you don't believe me, there is the left atrial appendage. What is the best way of telling the left from the right atrial appendage? The narrow opening. And could you wish for a better example of it than what you see there? There is the pectinate muscles confined in that appendage. And what does that appendage remind you of? Yes, Bingo. Whose ear? Oh, goodness me, you've not Snoopy, right, Snoopy's ear. That is Snoopy's ear. Good night, you're forgetting these things very quickly. Snoopy's ear. This valve is the mitral valve. How do we know that is the mitral valve? It has, well, I didn't show you that. That would be the classical way. What have I shown you there that tells you that is a mitral valve? Well, and what are the chordae tendineae attached to? And how many papillary muscles? 2. Paired papillary muscles tells you it's a mitral valve. And as Dr. Al-Marsafawi said, when we look in there up the outflow tract, indeed, there is no attachment of the valve to the septum, confirming that it is indeed a mitral valve. And there, what am I showing you? Here. Cusps of, leaflets of the aortic valve. Is there anything the matter at all with this aortic valve, this mitral valve, this left ventricle, and this left atrium? Yes or no? What's the matter with them? Is the problem in this heart on the left side? No, there isn't. It's a trick question. Indeed, I mean, the anatomy can be distorted, and if you look carefully, you can see that there is a bulge here in the ventricular septum. But basically, the anatomy here on the left side of the heart is normal in terms of anatomic terms. In anatomic terms, this is a relatively normal left ventricle. It has a relatively normal mitral valve. It has an aortic valve coming off it with fibrous continuity between the leaflets of the aortic valve and the mitral valve. And as Dr. Vogel said, the suprasystemic pressure, or the buildup of pressure in the right ventricle, can cause the septum to bulge across. But basically speaking, in general terms, the left side of this heart is all right. So I have shown you here a heart with what sort of segmental connections? concordant. There is nothing the matter with the way this heart is put together. There is a defect within the oval fossa, but in fact the flap valve is overlapping the upper margin of the oval fossa. So if this heart had a normal passage through the right ventricle, that defect in the oval fossa would be of no significance, because the left atrial pressure would be sufficiently high to close off the fossa. The reason that it is patent in this way is, of course, because that is the only way in this particular heart for the blood to get into the systemic circulation, into the circulation, because there is pulmonary valvar atresia. But in basic terms, this is a normal heart. Okay? So the problem is exclusively there. The problem is at the ventriculo-arterial junction between the infundibulum of the right ventricle and the pulmonary trunk. The distribution of the pulmonary arteries in the lungs of this case is entirely normal. There is initially an arterial duct, a very big arterial duct. There you see I'm passing my probe round the back of the arterial duct. So there is patency of the arterial duct. Pass the probe up and you see it goes clearly through and down into the descending aorta. So the pulmonary circulation in this heart has developed relatively normally. In fact, in this particular case, the surgeon augmented the supply to the lungs with this. What is this thing? Conduit? What sort of conduit? What do we call that? BT shunt? What sort of BT shunt? Modified. What's BT stand for? Blalock-Taussig shunt. Who was Taussig? Don't give them all the answers. Who was Taussig? Not quite Texas Children's Hospital. She was never at Texas Children's. She was the Harriet Lane Clinic of Johns Hopkins Hospital in Baltimore. And as Dr. Vogel says, Helen Taussig was the mother of pediatric cardiology. She only died, in fact, 2 or 3 years ago. Who was Blalock? He was a surgeon. And why did Helen Taussig have to go to Blalock to construct this shunt in the first instance? Do you know the story about this? Dr. Taussig went to Dr. Gross, Dr. Robert Gross, who was the chief of pediatric surgery at Harvard Medical School, and said, Dr. Gross, I have had a wonderful idea to palliate children with cyanotic congenital heart disease. I would like you to turn the subclavian artery down and put it into the pulmonary artery. And Dr. Gross said, Dr. Taussig, I am in the business of correcting lesions, not creating them. And so she then went to Blalock at her own clinic, and he agreed to turn down this subclavian artery, and thus was born, probably, the area of corrective, the biggest impetus for correction of congenital lesions. But now, instead of turning down the subclavian artery, you see that the surgeons place a conduit between the subclavian artery. Here is the right subclavian artery. You see they place this conduit down from the right subclavian artery to the right pulmonary artery. There you see it's beautifully placed there. So we call this a modified Blalock-Taussig shunt. And the shunt is made of what? Gore-Tex, absolutely. Many of you have probably seen Gore-Tex in your overcoats or what have you, where it keeps out the water. Here it keeps in the blood. So there is a modified Blalock-Taussig shunt. Okay, now that is an aside. That is me introducing a spot of levity to this very serious meeting. Let's come back to this lesion. At what stage do you think this lesion develops during growth of the embryo? Does it develop early or does it develop late? Relatively speaking. Why do you think it develops late? And the rest of the heart is normal. The key point in this heart is that the connections are normal. So, at what stage of development is the heart itself formed during embryonic life? At what stage is the septum complete? At what stage are the chambers all connected one to the other? And what stage is the embryonic interventricular communication closed? After the 8th week. Very good. So, we can presume that in this particular case, this atresia of the pulmonary valve occurred after 8 weeks of development. What about the heart I showed you just a few moments ago? When do you think the insult developed in that heart? Earlier, because the ventricular septum never closed. And it's because of that, I believe, that in pulmonary atresia with ventricular septal defect, you're more likely to get abnormal circulation in the lungs. Because in this heart, everything developed correctly, the pulmonary arteries developed correctly, the arch system developed correctly, so that there is an arterial duct supplying the pulmonary arteries, and then at a subsequent stage, when the pulmonary valve itself became atretic, all is in good shape to continue going. But after birth, of course, once the duct closes, unless something like this is instituted, this patient is in big problems. And where are the problems going to be after birth in this patient? This is obviously only a very small part of, although it's the most important part of the lesion. Where do you think the most important problems are going to be in patients of this type? Why is the duct going to be a problem? You can get over the... Why do you think this patient died? I mean, all that's happened is a shunt was put in. And probably it shouldn't have died, but be that as it may. In subsequent treatment, where are the problems going to be? The right ventricle. Here is the problem in this case. So the consequence of atresia of the pulmonary trunk is the effect that it has on the right ventricle. And that's why I showed you that first half, in which I illustrated to you that the right ventricle was relatively normal. There was a ventricular septal defect, but that is an easy matter for the surgeon to correct. All the problems in these hearts relate to the right ventricle. And you relate those problems to the effect that this atresia has on the components of the right ventricle. Now, how many components does a normal right ventricle have? And what are they? Inlet, apical, trabecular, and outlet. And so what we are going to look at is the consequence of the effects of the cavity of these three components, inlet, apical, trabecular component, and outlet, of atresia at the ventricular arterial junction. And I'm going to also show you the different types of atresia that we can have here at the ventricular arterial junction. Now, which component of the heart do you think has been most affected in this particular case? We've had one vote for the outlet, and we've had several votes for the apical trabecular part. The inlet is also not good, but if I ask you in which area of this heart is the hypertrophy most obvious, in the trabecular part, because you see that in reality all of this part has been squeezed out. You can see that muscle extends from there all the way out to the apex, and what has happened, I believe, and this is only speculation, is that hypertrophy of the muscle in response to this complete obstruction of the ventricular arterial junction has obliterated this apical trabecular component. And I'm now going to show you a series of hearts which illustrate that the greater degree of hypertrophy, the more compromised is put upon the outlet component. And eventually the outlet component also becomes obliterated, leaving only the inlet, and then the smaller the inlet, the more hypoplastic becomes the orifice of the tricuspid valve. And from the point of the clinician, there is a direct relationship in this entity between the circumferential diameter of this tricuspid valve and the cavity dimensions of the right ventricle. So what I am going to show you is a spectrum of malformation with increasing obliteration and increasing wiping out of the cavity of the ventricle by the hypertrophy of its walls. Okay? Now you should not interpret this to mean that the apical component here is absent. In the past, we promoted this concept of the tripartite ventricle, and we said that in pulmonary atresia like this, here the cavity of the ventricle is effectively the inlet plus the infundibulum. Can you see that? There's very little of the apical trabecular cavity left, but certainly there is evidence of the apical trabecular pattern and the apical trabecular cavity. This was interpreted to say that this was a bipartite ventricle. It has only cavity of inlet, cavity of outlet. In fact, clearly this ventricle is still tripartite. You can see that without any problem at all. There's the inlet, there's the apical part, there's the outlet. The apical part is overgrown, so the cavity is represented only by the inlet and the outlet, but this for sure is still a tripartite ventricle. Yes? So let's look at a series of these parts, and they're beautifully dissected. So here we're dealing with the same situation. There is the tricuspid valve. You see that if you look at it from above, the leaflets of the tricuspid valve, rather narrow orifice to the tricuspid valve. Here now is the hypertrophy, and there's significantly more inlet hypertrophy of this one. Here is the very major hypertrophy of the outlet, but now you see that not only is the apical trabecular part overgrown, but also the infundibulum is overgrown. In fact, if you look at it very carefully, if I can persuade the shadows to stay away, you can just see, can you see that? You can just see the track of the infundibulum, leading up here. But now, when we look at the pulmonary outflow tract, you see that at the base of the pulmonary valve, there is what looks like valvar tissue here, but in reality, that is the tri-radiating sinuses of Valsalva. But in fact, there is, well, there might be just a smidgen of valvar tissue there. You can see that there is an infundibular tract coming up here. Maybe there is a tiny tract there, but if anything, there is only just the smallest of imperforate membranes between the cavity of the pulmonary trunk and the obliterated infundibulum. Now this is still clearly normal chamber connections. The pulmonary trunk is still connected to the right ventricle is connected to the right atrium, the connections are concordant, but as there is increasing overgrowth of the infundibulum, this wipes away the pulmonary valve. And this, I believe, is the single most important feature in pulmonary atresia with intact septum, to differentiate between obliteration of the infundibulum and an imperforate pulmonary valve. Now let me show you again another case with unequivocally an imperforate pulmonary valve. In fact, this was the one I wanted to show you first. I picked up the wrong heart then, because in this one you see that there is not nearly as much hypertrophy of the inlet. You see that the outlet is reasonably well represented. Here is the tension apparatus of the tricuspid valve. Unequivocally an infundibulum here. And isn't that beautiful? Can you see that domed valve that comes up to a point? and is clearly imperfect. And that valve, of course, is just waiting for the cardiologist to pass something up here with a catheter. Now we use a laser wire. You could equally use just a wire or just a direct needle or something, and then whoop, and you're through into the pulmonary trunk. So now the cardiologist is able to deal with this case. And so it's crucial to differentiate those hearts in which there is an imperforate pulmonary valve. There is another one here that I would like to show you, if you bear with me for just a moment. Okay. Here it is. So the crucial feature is to find the imperforate pulmonary valve. And there, seen from above, we have dissected down to show you the imperforate pulmonary valve. You see there that the sinuses of Valsalva stop short. In the middle of the valve there is a nipple. Underneath the valve there is an infundibulum. And there you see the infundibulum. So the key feature in pulmonary atresia with intact septum is whether there is an infundibulum leading up, and there, got behind it there. Whoops, can't get it into the right place. Bear with me. These hearts are very small. There we are. That goes right up into the pulmonary valve. It's not showing terribly well. If I turn the heart over, there is, I think you can clearly see, looked at there, you see how, that's a beautiful picture. You can't ask for a better look than that. There are the three sinuses of the pulmonary trunk. The walls of the sinuses stop there, and in the middle is the imperforate pulmonary valve. And when you find a pulmonary valve like that, there has to be an infundibulum on the underside. And that is what you are seeing in cross-section. In this heart, there you see the infundibulum, there you see the imperforate valve, and above it, the pulmonary arteries, fed by arterial ducts. So in this particular case, the mural hypertrophy is not that bad. You can see that there is some hypertrophy in the apex, so there's a degree of overgrowth of the apical part. The inlet is nicely formed. Tricuspid valve is particularly nice, but there is an imperforate pulmonary valve. Now if we look at a worst case, the bigger heart, but in this particular heart, you now see that the musculature infundibulum really does stop short. See how the infundibulum has narrowed down, and see how muscle has grown across here? And now if I turn the heart and show you that blind-ending pulmonary trunk, we can now see the rims between the sinuses coming down here. If I can persuade this to turn around all the way, so that I can look right down on top of it for you. There is the blind-ending pulmonary trunk, and at the base of the pulmonary trunk this time, there is no valve. You see, there is the ridge I showed you just a moment ago. That comes to the middle of this blind-ending pulmonary trunk. This time, turning it back, show it you with the normal orientation. This time, there is a muscular rim between the outlet and the wall of the pulmonary trunk. Now I have said that previously that if there is a muscular rim, that is much more difficult for the cardiologist to pass his probe through or his laser through. But you can see that in this particular case, even though there is a degree even though there is muscular atresia between this blind-ending infundibulum and the pulmonary trunk, the tract of the blind-ending infundibulum would lead you directly towards the pulmonary trunk. So probably in this particular case, there would not be that much difficulty in passing a laser across there. And you can also see that in this particular case, the apical hypertrophy is not that severe. So the cavity size in this one is reasonably well formed, despite the fact that there is muscular atresia. So it's not a hard or fast rule. And in fact, I can show you one more case. We're getting lots of water on here. Can we move up the... This case is really tiny. And this, the apical part is really overgrown. But in this instance, there still is an infundibulum. There is the infundibulum that I've got my probe up. You can see rather nicely the whole of the infundibulum. And in this instance, we've dissected it rather nicely to show you the nipple of the valvar pulmonary atresia. So in fact, the hearts I am showing you, which are the best hearts in our collection to illustrate the features of pulmonary atresia, are not terribly representative, because usually when there is this degree of muscular hypertrophy, there is also muscular atresia. This heart does show you another very important feature of pulmonary atresia, however, and that is that when you have pulmonary atresia with intact septum, the high pressure in the right ventricle forces the blood out to the coronary arteries. And you can see these rather large communications here, which we call sinusoids. These sinusoids feed through to the coronary arteries. And if you look at this coronary artery, you can see that the coronary artery itself is dilated. You can see that this stretches up into the anterior interventricular vessel. If you look on the posterior surface, the course of the posterior interventricular artery is also a little dilated. And in these circumstances, the coronary arterial circulation is dependent upon flow of blood through the right ventricle. And this is called the right ventricular dependent coronary circulation. And we know from examination of patients who die that when you get this arrangement, right ventricular dependent coronary circulation, so that's a very bad prognostic feature. But usually you get the right ventricular dependent coronary circulation when there's muscular atresia. It's unusual in this case to find it with valvar pulmonary atresia, and that just shows you that there's no perfect rule in congenital heart disease. This heart also shows one very important feature of pulmonary atresia with intact ventricular septum, and that is, despite the tiny size of this right ventricle, and going along with the tiny size of the right ventricle is the tiny size of the tricuspid valve, so despite the fact that the right ventricle is tiny, the pulmonary arteries are still of pretty good size. And if you compare the size of that pulmonary artery to the aorta, it's damn near as big as the pulmonary artery. The blood has initially been fed to it through the duct. This is a case where the duct did close and then the patient died very early. There wasn't surgical rescue in this case, but it does illustrate how the problem is not in the pulmonary arteries, even when the ventricular abnormality is very gross. All right? So let me go back and summarize. Well, no, let me show you one more heart first. Is one more in which there is muscular atresia. This is the last of the sequence. You see that the coronary arteries are prominent, suggesting that there's been some degree of right ventricular blood forced into the coronary artery. You see that the tricuspid valve itself is